All right. Well, we'll go ahead and get started with this year's first sports ultrasound case series presentation. So I have the pleasure of introducing Dr. Wikien Pinto. His background is he completed his medical school at the Jose Maria Vargas School of Medicine in Venezuela. And then he followed this with an internal medicine residency at Jefferson Einstein Philadelphia Hospital. And then he was an assistant professor of clinical medicine at the academic hospital for the University of Cincinnati for 4 years before now joining the Vanderbilt University Medical Center, where he currently is the primary care sports medicine fellow. And today he's going to be giving us a presentation on ECU subluxation and instability.
All right. Thank you, Dr. Schaff, for this kind of introduction, and Happy New Year, everybody. I hope you can see my slides okay.
Yep, that looks good.
Okay, thank you. So, yeah, as Dr. Schaff said, we're going to talk about extensor carpi ulnaris subluxation and instability today. I do not have any financial relationship to disclose. This is the outline for the talk for this talk, and we're going to start with a brief case presentation, some scans consideration, the scanning protocol, images pertaining to the case, this the scanning report, and a brief discussion about our findings. So our patient is a 30-year-old right-hand dominant male, weightlifter with chronic left ulnar wrist pain and popping. This pain began progressively and gradually a few years prior with weightlifting activity, and it persisted. It was located on the left ulnar wrist, and he felt instability and a frequent popping. And physical exam, he was tendon on the ulnar wrist, along the ulnar wrist, and when we evaluated him during pronation and supination of the wrist, we could see positive ulnar wrist tendon subluxation. So we move forward with our first imaging modality, which is the X-ray, to rule out any bony pathology. We did find a mild ulnar positive variance, but otherwise it was unremarkable. And then we continue with our ultrasound evaluation. And why we decided to do this is because this is a good method to evaluate pathology and do it in dynamic evaluation. We started with selecting our high frequency transducer, linear array, first with mid footprint, and then changed to a small footprint to focus more on the area of interest. Our patient was positioned in supine position with the wrist pronation during static scanning. But this position can change during dynamic scanning to allow better visualization of the area of interest. And the protocol we selected to evaluate our patient is the dorsal and ulnar wrist ultrasound protocol. And it includes the evaluation of the radiocarpal joint, the distal radio-ulnar joint, or DRUJ, and the first extensor compartment with its tendons, adductor pollicis longus and extensor pollicis brevis, and the superficial radial nerve, the second extensor compartment with the extensor carpi carporadial longus and extensor carporadial brevis, a third extensor compartment with the extensor pollicis longus, fourth extensor compartment, extensor indices and extensor digitorum, fifth extensor compartment with the extensor digiti minimi, and sixth extensor compartment with the extensor carpi ulnaris. We will also include the TFCC evaluation as well as the ulnocarpal joint, and at the end, a scapholunate joint and ligament. So why we decided to choose this protocol in this case was indicated for evaluation of wrist instability and pulping. But if you're suspecting other pathology, you can also use this protocol. Other examples are, for example, proximal intersection syndrome or distal intersection syndrome, as well as the evaluation of scapholunate instability, lunotraquetral joint or ligament instability, and in this case, ECU subluxation and instability. So our first image, we started with our home base and placing our probe as an axial view at the level of the Lister tubercle. We label our pictures for orientation purposes. You can see here. And also we included a picture of the corresponding anatomic structure with the probe, also for orientation. We can identify the Lister tubercle here. And this is important because every time you scan the dorsum of the wrist, you might think that you're in one compartment or the other. So if you have any doubt, you can go back to the Lister tubercle. And on the radial side, you will see or will have the second compartment. And on the ulnar side, you will have the third compartment. So we're going to start our scanning protocol from the radial side to the ulnar side, and from the proximal to the distal side, as seen on the video below. So we're starting evaluating our first joint, which is the radiocarpal joint. And we do this rotating our probe 180 degrees and on long axis, where we can see on the left side is the proximal side with the radius, and more on the right side or the distal side, the capitate. And this is our first radical joint with the lunate in the middle. We can also see if we move more radially the scaphoid, and this will be useful to look for any effusion, any cortical irregularity, any synovial hypertrophy, suggestive of possibly an inflammatory process within that joint. Also, in terms of cortical irregularity, there can be signs of a possible fracture if there is disruption of the periosteum. Our second joint will be the DRUJ, or distal radioulnar joint. Again, we have our probe on axial view, and we put it on top of the Lister tubercle, our home base, and then we slide it towards the ulnar side up until the ulna. And we can localize the DRUJ, again, looking for any effusion or maybe cortical irregularity along the radius and the ulna, or synovial hypertrophy. Starting from the radialmost compartment, our first extensor compartment, and it contains the abductor pollicis longus and the extensor pollicis brevis. This is a common compartment to evaluate. These are the tendons that are involved in decurvent tenosynovitis. And then evaluating this compartment, we are going to see how the tendons look like, and we're going to look for any fluid around the tendons, suggestive of inflammatory process, tenosynovitis, changes of the cogenicity of the tendons, suggestive of tendinosis, or also we can even use Doppler to see if there is any increase in flow that will also be suggestive of tenosynovitis. Sometimes we can also see tendon tears, and we can further evaluate the tendon on not only axial view, but longitudinal axis to also look for any pathology. At this point, we can move proximally. Those tendons, you can follow them from the first compartment distally and proximally, all right, to look for the integrity of the tendon. And if we move proximally, we will find our first intersection of the tendons. This is actually, as you can see on the dynamic evaluation down the video below, this is actually the second compartment on the right side, on the ulnar side, and above the second compartment, we can see the movement of the APL and EPV towards the radial side. And at this point, there could be signs of inflammation, suggestive of possible proximal intersection syndrome if the patient is complaining about symptoms in that area. So we will be looking for some fluid or some dyskinetic motion of the tendons sliding one above the others. And also at the level of the first compartment, we will identify our superficial radial nerve. And if we follow it distally, we can see the lateral, how it branches into the lateral and medial branch. And we can also follow it proximally to evaluate for any pathology of the superficial radial nerve. And in this case, we will correlate also with the patient's symptoms if the patient is complaining of any numbness or tingling on the dorsal aspect of the hand. Again, this is a sensory nerve, so the patient, if he has any pathology related to this, wouldn't complain about any weakness. So we move next to the ulnar side, and then we encounter the second extensor compartment with the extensor carpi radialis longus and extensor carpi radialis brevis, as shown by the white arrow. And the Lister tubercle should be more on the ulnar side. We can follow distally these two tendons, and then we will see the EPL or the extensor pollicis longus sliding above those two tendons. So this will be our second intersection of the tendons, but this is more distal. So again, as the proximal intersection, we will be looking for any fluid around that area or dyskinetic motion of the tendon above the tendons of the second compartment, as seen here, how it slides above them. And that could be suggestive of possible distal intersection syndrome if the patient is complaining of symptoms in that area. We move more again to the ulnar side, and then we will see our third compartment, which contains the extensor pollicis longus. And then we also saw it on the previous video, sliding above the second compartment tendons. Our next compartment on the more ulnar side would be the fourth compartment containing the extensor indicis and the extensor digitorum, the tendons of the extensor digitorum, and our fifth compartment on the same view, containing the extensor digiti minimi. Again, when we evaluate every compartment that contains the extensor tendons, we will be looking for any pathology related to the tendon, like any fluid around the tendons or any change of the echogenicity. We can also evaluate them and we follow them distally and proximally and evaluate the integrity of the tendon and looking for any tear or other pathology. We can also change our probe into longitudinal view and also to evaluate the tendon for pathology. And the most ulnar side, we will find a sixth compartment that contains the ECU or Extensor Carpi Ulnaris that we're going to talk about today. In our patient, we could see the tendon in the middle of the screen. Below the tendon, it's the ulnar and the ulnar groove. Above the tendon, we can see other anatomic structures. We will be looking for the subsheath, which is a fine layer of tissue that contains the tendon within the groove or should contain it within the groove, and a more fibrous tissue above it or a more fibrous layer above it, which would be the extensor retinaculum. And in this static ultrasound view, we can see that the tendon is already already subluxed from the groove towards more the ulnar side, and up to 50% of subluxation is considered normal. Again, this is an static view, so when we evaluate it dynamically, we can see if there's more than 50% subluxation, and if that correlates with our patient's symptoms. In this case, looking at the subsheath above the tendon, we can see that there is a possible disruption on the ulnar side where the tendon is subluxing. Again, with this ultrasound evaluation of the tendon, we will look for any fluid around the tendon that will suggest a possible inflammatory process or changing the echogenicity of the tendon with possible tear. And if it is frequent, if the patient is having symptoms and there is tenderness, that you might find or may find some signs of tenosynovitis, of inflammation, because of the continued friction of the tendon going in and out of the groove. We also evaluate, as we said before, every tendon if we're interested on or looking for pathology. In this case, the ECU on a long axis, and again, looking for any fluid around the tendon and changes on echogenicity, possible tear along that tendon, or signs of tenosynovitis. This view, we can identify the more proximal side on the right side of the screen and more distal with the fifth metatarsal on the left side of the screen. We proceeded with dynamic evaluation of the ECU. In this case, we had our patient, as we said before, in supine position with the wrist impronation, but we can also have our patient bend his elbow, and so to allow easier evaluation of the joint while pronating and supinating with this motion. We will probably need a good amount of gel, and I try to keep that probe in that position, localizing the groove and trying to identify the tendon while moving the wrist, so you can visualize the movement of the tendon. In this case, we can see in this video that the tendon goes in and out of the groove towards the ulnar side, and subluxing at least more than 50%. And in our case, it correlates with the clinical presentation of our patient, which is pain during pronation and supination and popping. The other structures that were better visualized in the static ultrasound image can also be seen here. However, one of the most important thing is to localize the tendon and see if there is more than 50% subluxation. In this case, it's towards the ulnar side, but it can also happen towards the radial side, which is less common, but it's possible. This is another video of the dynamic scanning. And then we can also see this kinetic motion of the tendon when it kind of like goes in and out of the groove, which may elicit the pop of the patient when pronating and supinating the wrist. We continue our scanning protocol, and on the ulnar side, longitudinal view, we can evaluate the triangular fibrocartilage complex, or TFCC, and the ulnar carpal joint. Again, looking for any effusion there in that joint, or any partial tearing of the TFCC, which could explain patient symptoms if you're not thinking that the ECU subluxation are responsible for the patient's symptoms. And we finalize our scanning protocol with the evaluation of the scapholunate ligament or scapholunate joint, again, looking for any effusion there. And it's good to know that this is one of the most common injured carpal ligament with instability, and this is a static evaluation, but it can be also evaluated dynamically, looking for an increase in the gap between the lunate and the scaphoid, and also any cortical irregularity or pathology of that joint. So our report for this ultrasound evaluation, the indication was chronic left ulnar wrist pain and popping. We used the high frequency linear array mid footprint and small footprint probes. Our findings were the radiocarpal joint. We didn't find any evidence of joint effusion or synovial hypertrophy. Also the distal or DRUJ, no evidence of joint effusion or any osseous abnormality. From the first compartment, we evaluated the tendons and we didn't see any tear or sign of tenosynovitis. We also evaluated the intersection, the proximal intersection of the first and second compartment and tendons, and we didn't see any fluid or signs of tenosynovitis, as well and we also evaluated the superficial radial nerve. We didn't see any abnormality there. We moved radially to the extensor, second extensor compartment. We didn't see any tendon tear or tenosynovitis. And the distal intersection between the second and the third compartment, didn't see any fluid there either. And evaluated subsequently the third, the fourth, and the fifth extensor compartments. And none of those tendons had any irregularity. They look normal. And we didn't find any tearing or signs of tenosynovitis. And then we evaluated the sixth extensor compartment where the ECU is. We didn't see any ECU tendon tear, signs of tendinosis or tenosynovitis. However, we did see that there was a complete tear of the ulnar side of the tendon subsheath at a static evaluation. The tendon was partially subluxed, less than 50%. And with dynamic evaluation, pronation and supination, we could see a complete ECU subluxation over the dorsal ulnar styloid. We finalized our protocol with the evaluation of the TFCC and the ulnar carpal joint, where we didn't see any sign of effusion or evidence of peripheral TFCC tear, and the scapholuni joint and ligament, which were intact. So our conclusion was there was a complete tear of the ulnar side ECU tendon subsheath, resulting in dynamic tendon subluxation and instability. And we can see it here on these pictures of a cadaver where the ECU subsheath is, where the white arrow is pointed at, and above that, the extensor retinaculum. So this picture on the left side is an intact ECU subsheath, and on the right side, we have another picture with torn ECU subsheath. This picture, we can see that the extensor tendons at the level of the wrist are contained by the extensor retinaculum, which is a fibrous layer that prevents the extensor tendons bowing, and it actually runs along the dorsal aspect of the wrist from the distal radius to the ulnar side and inserts at the pisiform antequatum. But below that extensor retinaculum at the ulnar, above the ulnar bone, there is the ECU, and below the extensor retinaculum and above the ECU, we can see the subsheath, which is a fibrous tissue that contains the tendon in place, and it is localized within the ulnar groove, and its main function is to keep the tendon in place during pronation and supination. This was first described and as a fibro-osseous canal at the distal ulna, and it extends at least 1 to 2 centimeters along the distal ulnar groove, containing the tendon, preventing its movement towards the sides. As seen on the left lower corner picture, this is a collagenous tissue, and this subsheath is attached to the ulna on the radial and ulnar side, containing the tendon under it. Along with the ulnar groove, it forms the fibro-osseous canal at the level of the distal ulna. Also, for surgical purposes, 3 types of ECU subsheath rupture or pathology has been described. And we can see on the picture on the right side, a type A, 3 types. Type A with rupture of the subsheath attachment towards the ulnar side with the tendon coming out of the groove. The type B is a rupture more on the radial side with also the tendon coming out of the groove or subluxing out, and it can even overlay the subsheath and prevent healing. And type 3, where the subsheath attachment to the ulnar side of the ulna is detached, and the tendon sublux in and out, but the subsheath is not torn. So it has been described that on the ulnar side of that subsheath, there is extra connective tissue that its main purpose is to not only keep the tendon in place, but sustain the forces when there is subluxation and pronation and radial deviation, and reinforce that that subsheath or that layer that contains the tendon in place, preventing subluxation and subsequent tendon pathology, as we can see in the picture in the middle. And with that, I conclude my case presentation and scanning protocol. I'm open to questions.
All right. Thank you so much, Wikien, for kind of kicking out the case series presentation with this. So a couple just comments that I wanted to make that I thought this was a good case to kind of bring up is that with this ECU pathology is, I think it can obviously be pretty clinically obvious that this is the case, but I think there's still a huge role and benefit then for using the ultrasound. Number one, obviously, it's going to be the only imaging modality that's going to be able to dynamically evaluate the ECU tendon, whereas all other imaging modalities are going to be static. So you can truly confirm that there is subluxation of that ECU tendon. And as you had mentioned, typically for this to be considered, pathologic and abnormal, you're going to be looking for subluxation greater than 50%. And a lot of the time, you're going to have to do dynamic motion to make that happen. The other part, as you kind of alluded to in the anatomy portion of this, is that there's a lot of detailed information that you can get with the ultrasound as well, too, to kind of further clarify the subtype of ECU subluxation that's occurring and exactly potentially where the tearing of the subsheath is at. And obviously, this can be helpful and have implications for our surgical colleagues as well, too, in these cases that the patient may need to go on to a surgery if they fail conservative treatment. A couple other points that I just wanted to kind of make and hone in on that you had mentioned in the last slide is just the importance of knowing that for the ECU, the main stabilizer for it is going to be the subsheath. So once again, that extensor retinaculum overlies both of these, both the ECU and the subsheath, but it's not going to be the primary stabilizer for the ECU. What's going to provide that is that subsheath, and truly that subsheath is going to be strongest really along the dorsal ulnar aspect of that groove. And so that's going to be the primary area where you're most often going to get these subsheath tears occurring at, just because of the stress with that supination pronation movement. However, it should be noted that these tears can occur along the radial side. So just make sure that you're evaluating it for both those areas too. And don't be confused that subluxation can occur on either one of those sides. Additionally, with this case is just noting that, obviously with these ECU subluxation, it can be painful and it can cause symptoms, but it doesn't always mean that it's going to be causing a tendon tear, either a tendon tenosynovitis. Now, I definitely think that there can be cycles that patients will go through and have those symptoms, but it still, once again, doesn't mean that you're always going to have that pathology if these subluxations occur. But obviously, with the instability that it can occur with this, that obviously can still be the primary symptom that the patients are coming in with. And then I think just the last 2 points is in some cases you can have ECU tendon slips, and that can be a reason why sometimes you can have subluxation or the feeling that that's occurring. So just be aware that sometimes you can have variants of the ECU tendon, which can be a reason for that subluxation, that you can have it within the subsheath itself. And then, just lastly, obviously doing kind of a complete, protocol, as we had mentioned. I think definitely for the ECU, it's important to kind of evaluate the TFCC, underlying it. And in any cases that you're still concerned about TFCC pathology, obviously, and you may continue to go on and get an MRI for further evaluation as well too, if you start to see any secondary findings that there is a TFCC pathology. So those are kind of major comments that I just wanted to additionally make for the presentation, but obviously we'll open it up to anyone else that has any other comments or questions.
Yeah, hi, good morning. This is Doug Hoffman. Um, so how do you guys tend to evaluate dynamically? What position do you usually have the patient in?
Yeah, so usually for this, I'll start out in that pronated position, and then just having it kind of usually lying on the side of a table. Obviously, this can be very difficult. Sometimes I'll then even kind of bring up the elbow into 90 degrees of flexion and have the transducer. But usually, I'm just trying to hone in on that and use quite a bit of gel, just because obviously with dynamic motion, you can kind of lose that contact. But the key is that I'm always kind of doing that wrist circumduction motion where you're typically then going from pronation to supination. And usually it's going to be on that supination kind of movement that subluxation is going to occur. And then they should have then relocation of the tendon when you go back into that pronation movement.
Yeah, I mean, I would agree. I tend to do these with the elbow flexed to 90 degrees.
Okay.
And then exactly what you say is a lot of gel to maintain contact going from a pronated to supinated position. Can you throw up your first image of the ECU up there? So,
Sure.
as both of you pointed out, anatomy is key here. And, when you look at the groove of the ulna and on this image here, we see the subsheath. And if you look look radially, you see a hyperechoic triangle. That's called a linea jugata, and that maintains the radial stability of the ECU. The other important anatomic detail here is they don't see the retinaculum here. And so the
Hmm.
retinaculum is distal to where we would evaluate for instability. So it's important not only to image the ulna, within the ulnar groove, but also to scan distally and evaluate the retinaculum. And both the fifth and sixth dorsal compartments, so the extensor digiti minimi and the ECU, interestingly, do not have the retinaculum attach on to the ulna or any bone. So
Hmm.
they're encased within the extensor retinaculum. So again, it's important when you're imaging ECU, to scan distally to the retinaculum because you can have a stenosing tenosynovitis. In my experience, which you've already alluded to, there are three main categories of ECU pathology. So the first is sort of attritional tendinosis, and attritional tendinosis is quite common. And so you're going to see longitudinal clefts. You often see some flattening of the ECU tendon. And key here is to correlate your sonographic findings with sonopalpatory pain because it's
Hmm.
kind of an age-related process. But people can have pain there. And so again, the sonopalpatory pain is readily available because it's a superficial structure. Secondly, would be a true tenosynovitis or
Hmm.
inflammatory process. And the ECU, in my experience, or the sixth dorsal compartment, is the most common compartment that I see a true inflammatory tenosynovitis, with the fourth dorsal compartment being the second one. And so it's also a compartment I scan very carefully when I'm worried about a patient with inflammatory arthropathy. And then the third is instability. And again, in my experience, and maybe it's just the population I see, I tend to see more young females with symptomatic uh, dislocation of the ECU, most likely from subsheath laxity rather than an
Hmm.
actual tear, whereas a traumatic type tends to have a tear of the subsheath. So ECU is I mean, the sixth dorsal compartment is a complex, but kind of a fun compartment to image, and did a nice job reviewing the pathology in a nice case.
Yeah, yeah. Thank you so much for those additional comments, Doug. Yeah, I mean, I think this is one that I was talking to Wikien about it. Is that it once again it seems clinically obvious and it seems very simple, but when you go into this, there's a lot of
Hmm.
layers to kind of dig through and a lot of nuance to go through and pathology and anatomy to know for this, just as you alluded to with the extensor retinaculum, the subsheath, and just knowing the individual, attachments, for those areas, just so that you can further, be specific about the pathology that you're talking about, especially once again with the subtypes, because obviously, you had mentioned the population that you're seeing a lot with is going to be this kind of, third type or type C that we see here on the slide, which sometimes can have different implications, for treatment that you're thinking about than if you have a true subsheath, tear that may need, reconstruction, or something like that from a surgical, standpoint. So.
Yeah, I would agree.
I think we have one question that says, do we always refer to hand surgery or some be able to be treated conservatively? I would say the majority are able to be treated conservatively. So a lot of the time you can try to do, bracing, for these patients, also work on any type of occupational or physical therapy. And then in addition, just working on, the ergonomics and biomechanics for whatever sport or activity that they're participating in. And majority of times, these patients can have at least stabilization of that area, or at least decrease their symptoms. Once again, the subluxation may still occur in some cases, but it doesn't mean that it's always going to be symptomatic. But sometimes in these traumatic cases or that are recalcitrant to conservative treatment, then there is surgical treatment options, including reconstruction of that subsheath.
Exactly. And depending on the type also, if we're talking about type B, when the tendon comes out and then lies on top of the subsheath, so that prevents the healing in conservative management. So that would be maybe an indication to refer to the hand surgeon.
All right. Otherwise than that, that's the end of today's presentation. Like I said, we'll be then kicking off the fellows presentation then for the next 6 months through June. That we'll be doing this every 2 weeks on Friday. So once again, thanks for going through the first presentation of the year weekend. Thank you.
Thank you, everybody.